Common alterations of the endocrine system. This one is going to focus on diabetes, type 1 and type 2. Diabetic statistics. As of July 2017, the CDC reports that an estimated 30.3 million people of all ages, or 9.4% of the U.S. population, has diabetes, and this was found during a study in 2015. The CDC, the Centers for Disease Control, not only monitors, like infectious diseases, they also look at other diseases that impact our lifestyle, and diabetes is one that they are closely monitoring. According to the World Health Organization, or WHO, the number has risen from 108 million in the 1980s to 422 million in 2014 worldwide. We're not just looking at America, we are looking at the whole globe with that. 1.66 million deaths were reported that correctly correlated to diabetes annually. The World Health Organization projects that diabetes will be the 7th leading cause of death by the time 2030 gets here. The American Diabetic Association, which is a really good resource if you need to do any diabetic teaching or anything, or just need to know some more information, is a really good website to go to. They have broken it down in just a few statistical bits of information. 7.4% of non-Hispanic whites have been diagnosed with diabetes, 8% Asian Americans, 12.1% of Hispanics, 12.7% on non-Hispanic blacks, and 15.1% of American Indians or Alaskan Natives have been diagnosed with diabetes. And when we're looking at the diagnosis of it, we're not looking at type 1, type 2, we're looking at the whole, diabetes of it. They have either diabetes type 1 or diabetes type 2 when we're looking at the statistical information on this. This is just another continuation of the breakdown of the diabetic statistics information. The breakdown of Asian Americans breaks it down into Chinese, Filipinos, Asian Indians, or other Asian Americans, which you can see it kind of fluctuates just a little bit with it. And they also do that among the Hispanic adults with that, looking at Central and South America, Cubans, Mexican Americans, and for Puerto Ricans. So you can see there is just a really kind of wide range of people that have it. I mean, it's just not saying only Filipinos are going to be a high risk at it. You can see, like with the Asian Americans, the Chinese are the lowest out of the group, and that's probably because of how they eat. A lot of fresh fruits and vegetables and fish, a lot of it. They don't have a lot of high fat in it. There's not a lot of obesity in the Chinese right now. So you can see where, maybe diet is going to play a part in that. And we'll talk a little bit more about that as we get along with the lecture. Now we're getting into the cost of it. And like I said, the ADA, or the American Diabetic Association, helps the CDC gather this information. So $245 billion total cost of diagnosed diabetes in 2012. There's $176 billion for direct medical costs, $69 billion in reduced productivity. So they're looking at how much it costs totally to treat them once they have been diagnosed. We're looking at education, we're looking at medication, which is really, really expensive, whether, especially insulin, oral anti-diabetic, what happens with them because they're more prone to illnesses and stuff, what happens to them with missed days at work, and it's just kind of almost a big drain on the healthcare system. So they've been tracking this for a while. Also on here, these are just some random examples that I found. I just kind of wanted to compare Kansas to some of the other states in the Union. Kansas approximately 293,860, or 12.6% of Kansans, people living in the state of Kansas, have been diagnosed with diabetes. 69,000 have diabetes but don't know it. Kind of a scary thought there. 749,000, or 35.5%, have prediabetes. These are the ones that are, their A1C might be getting up to like 5.8, something like that. They haven't really gone over the cusp of being said, yes, you have diabetes, you have prediabetes, you're showing some of the symptoms. Let's make some changes. Let's do our modifiable risk factors and see if we can get you down and keep you from going on over into the diabetic side. You look at Colorado, which is approximately has 416,301, or 9.8% of the state has diabetes. 118,000 have diabetes but don't know it. And 1,342,000, or 34.8%, have prediabetes. Large number of people that have prediabetes in Colorado. Then we'll go clear back over to the East Coast with the District of Columbia or Washington, D.C. Approximately 62,809, or 12.3%, have diabetes. 17,000 have diabetes but don't know it. 172,000, or 34.2%, have diabetes but don't know it. So you can see that that number, that should be prediabetes. The 34.2% should be prediabetes on that. I apologize for the typo on that. So 172,000, or 34.2%, have prediabetes. You don't need to worry about these statistical numbers. I just wanted you to have them and look at them and kind of see why they're saying now, with the way we eat, the diets, the Big Macs, the supersized meals, the Red Bulls, the pop and stuff we're drinking, as compared to what we were back in the 1970s and stuff. The numbers are climbing and growing exponentially. It's just doubling. So with all the obesity we have and our diets high in fat and stuff, we're putting ourselves at a higher risk for being diabetic, and these numbers show it. It just kind of shows, it isn't just going to be just a central United States that has problems with it. It's showing you kind of east, west, the center part of it on that. The numbers are very staggering as to far as, especially the ones with the prediabetes. But like I said, you do not have to know these numbers for the test. They're just something I want you to kind of look at, and as we go through the lecture, you kind of keep in the back of your mind, like, especially when it's patient teaching, okay, this is why it's very important we do patient teaching with somebody that is a pre-diabetic. Okay. The diabetes etiology and pathophysiology you can find on page 1121 of your textbook. Current theories link the cause of diabetes singly or in combination to genetic, autoimmune, and environmental factors when you're looking at viruses and obesity. And regardless of the cause, whether it was caused by genetic, environmental, or autoimmune, diabetes is primarily a disorder of glucose metabolism related to absent or insufficient insulin supply and or poor utilization of the insulin that is available. Basically, the body does not utilize the insulin like it needs to in the body. Okay, continuing on. Insulin is a hormone that is produced by the B cells of the islets of Langerhans of the pancreas. Under normal conditions, insulin is continuously released into the bloodstream in small amounts, with increased release of insulin when food is ingested. If you look over on page 1121 in your textbook, figure 48-1, it shows you normal insulin secretions. It shows you in the first hour to two after meals, insulin concentrations rise rapidly in the blood and peak about 1 hour. So it kind of shows you where the insulin is, where it's peaking and kind of dropping back down with it. Insulin, remember, lowers the blood glucose and facilitates a stable normal glucose range of approximately 70 to 110 milligrams per deciliter. So the average amount of insulin secreted daily by an adult is approximately 40 to 50 units, or 0.6 units per kilogram of body weight. Insulin helps promote glucose transport from the bloodstream across the cell membranes to the cytoplasm of the cell. The cell breaks down the glucose to make energy, and liver and muscle cells store excess glucose as glycogen. The rise in plasma insulin after a meal inhibits glucogenesis, which enhances fat deposits of adipose tissue and increases protein synthesis. For this reason, insulin is an anabolic or storage hormone. So this is why when it's not being utilized, when you hear them, it's not, the body is not utilizing the insulin correctly. This is what it's talking about with it on that. So other hormones such as your glucagon, your epinephrine, your growth hormone, and cortisol work to oppose the effects of insulin and are referred to as your counter-regulatory hormones. These hormones increase blood glucose levels, one by stimulating glucose production and release by the liver, and decreasing the movement of glucose into the cells. The counter-regulatory hormones and insulin usually maintain blood glucose levels within normal range by regulating the release of glucose for energy during food intake and periods of fasting. On that. So that's kind of the introduction to what it is, and this kind of, so you need to kind of keep this in the back of your mind, what it does and kind of how it does. Okay, insulin promotes glucose transport from the bloodstream across the cell membrane to the cytoplasm of the cell. The cells then are going to break down the glucose to make energy, and liver and muscle cells store excess glucose as glycogen. The skeletal muscle and adipose tissue have specific receptors for insulin and are considered insulin-dependent tissues. Insulin is insulin is required to unlock these receptor sites, allowing the transport of the glucose into the cells to be used for energy. So in other words, it's going to have to cross through the cell barrier on that to be able to be used. Other tissues, example like brain, liver, blood cells, do not directly depend on insulin for glucose transport, but do require an adequate glucose supply for normal function. Although liver cells are not considered insulin-dependent tissue, insulin receptor sites on the liver facilitate hepatic uptake of glucose and its conversion to glycogen with it. Just a little background of it. Don't get tied up into the transport and stuff of that. This is just a refresher, remember, of what you studied anatomy and physiology to help you start thinking of the difference of type 1, type 2, and kind of what is going on in the body when you have these two have one or the two diseases. Okay, the counter-regulatory hormones and insulin usually maintain blood glucose levels within normal range by regulating the release of glucose for energy during food intake and periods of fasting. So basically, the thing to remember is the counter-regulatory hormones, which are your glucagon, your epinephrine, your growth hormones, and your cortisol, along with insulin. They help maintain your blood glucose levels, like when you're fasting. You know, they kind of help keep things going when you're not, they don't have that intake of food into the system. Same thing as you're eating. They kind of help. They work together to make sure that there is a homeostasis basically in the system. Everything is calm, everything is, cool basically in the system. So it's just, even though they're considered counter-regulatory, they work with the insulin together to make things work well, is the long and short of that. Okay, with diabetes, the long-term complications that are associated with it can just totally makes it a very devastating disease. Diabetes is a leading cause of adult blindness, end-stage kidney disease, and non-traumatic lower limb amputations. It is also a major factor contributing to heart disease and stroke. Adults with diabetes adults with diabetes have a rate of 2 to 4 times higher of having heart disease than adults without diabetes. And this also goes with the risk for stroke. If you have diabetes, it puts you at 2 to 4 times higher risk to have a stroke than somebody that does not have diabetes. In addition, more than half of the adults with diabetes, you're going to see they'll have diabetes, they're going to have high cholesterolemia, they're also going to have hypertension. So these all are working together basically to cause a big storm, a great storm. So this is why a lot of times if you have somebody with just diabetes, it's not just diabetes, because it's going to be impacting them. It's going to impact their eyesight. It's going to impact their integumentary system, because maybe they have diabetic neuropathy, which is where it goes away and just basically causes problems with the nerve endings, and because due to high glucose levels, then you get a sore on the foot, then you get that, and you get an infection. So you just have so many compounding factors and risk factors that it's just not, oh, it's just diabetes. You may be a healthy person and be diagnosed with diabetes, but later on down the road, you're going to end up having other complications with it. So that's why it's very, very important that we do preventative if we can, so that we can prevent people from getting diabetes. But if they end up with diabetes, then we need to work with them so they can be proactive and not have maybe a lot of the risk factors. We can reduce their chances of maybe having a heart attack with it. Okay, diabetes. What went wrong with it? So the thing to think about this is, I've already talked a little bit about it, now I'm pulling it all together for you. Diabetes mellitus is a group of diseases characterized by high levels of blood glucose resulting from defects in insulin production, insulin action, or both. The effects of diabetes include long-term damage, dysfunction, and failure of various organs, like I just talked about. Excuse me. Diabetes mellitus is a serious health problem throughout the world, and its prevalence is rapidly increasing. I've already taught, I'm not going to talk any more statistics with it, but just remember, it is the 7th leading cause of death in the United States, but it is likely to be underreported. So you have people that are dying from heart attacks and stuff like that, or dying from strokes, but it's not being reported that they died from diabetes complications. They're just being reported as they had a heart attack a lot of times. So this is what we're talking about when we're talking about underreported with that. Types of diabetes, we talked about this just a little bit. Type 1, type 2, and gestational are the big ones we're going to focus on. Type 1 is, you're going to hear, is going to be either juvenile or IDDM. So IDDM, you need to know, IDDM stands for insulin-dependent diabetes mellitus. You do need to know that for the test. So IDDM stands for insulin-dependent diabetes mellitus. It's type 1, also known as juvenile diabetes. Type 2 is non-insulin dependent diabetes mellitus, or NIDDM. You're going to see these abbreviations, so you do need to know these abbreviations. Just know type 2 is non-insulin dependent. Type 1 is insulin dependent on that. And then gestational diabetes. This is the one that happens during pregnancy, which usually, if a woman has, if they have problems with gestational diabetes, it puts them at a higher risk for developing diabetes later on in their life with it. Doesn't mean that they will, but it does put them at a higher risk for it. Type 1 diabetes. You can find this in your textbook on the bottom of page 1121. It is formerly known as juvenile onset or insulin-dependent diabetes. It accounts for up to 5 to 10% of all people with a diagnosis of diabetes, and it generally affects people under the age of 40, even though it can occur at any age. Okay, type 1 diabetes is an autoimmune disorder in which the body develops antibodies against insulin and or the pancreatic B cells that produce the insulin. Eventually, this will result in that there was not going to be enough insulin for a person to survive. Autoantibodies to the I'm sorry, I've mispronounced this word every time. Islet cells cause a reduction of 80 to 90% of normal function by hyperglycemia and other manifestations. A genetic predisposition and exposure to a virus are factors that may contribute to the pathogenesis of the immune-related type 1 diabetes. The predisposition to type 1 is usually related to the human leukocyte antigens, the HLAs, And theoretically, when an individual with a certain HLA type is exposed to a viral infection, the B cells of the pancreas are then destroyed either directly or through the autoimmune process. The HLA types associated with an increased risk of type 1 diabetes include the HLA-DR3 and the HLA-DR4. You do not need to know that for the test. This is just some background information on type 1 diabetes, so you do not need to know that. Idiopathic diabetes is a form of type 1 diabetes that is strongly inherited and not related to autoimmunity. It only occurs in a small number of people with type 1, and most often Hispanic, African Americans, or of Asian ancestry. Latent autoimmune diabetes in adults, or LADA, is a slowly progressive autoimmune type of diabetes of type 1, and it occurs in adults and is most often mistaken for type 2. Don't need to worry too much about that. Just kind of know that type 1 diabetes is an autoimmune disorder with it. And it's just typically more of a genetic predisposition to it. With type 1 diabetes, the islet cells autoantibodies responsible for the B cell destruction are present for months to years before the onset of symptoms. Manifestations of type 1 develop when the person's pancreas can no longer produce sufficient amount of insulin to maintain normal blood glucose levels. Once this occurs, the onset of symptoms is usually rapid, and patients often present with impending or actual ketoacidosis. The patient usually has a history of recent and sudden weight loss, as well as the classic symptoms of polydipsia, which is excessive thirst, polyuria, frequent urination, and polyphagia, excessive hunger. Need to know these. You need to know what polydipsia is, which is excessive thirst, polyuria, which is frequent urination, and polyphagia, which is excessive hunger. The individual with type 1 diabetes requires insulin from an outside source, and they consider this exogenous insulin to sustain life. This is where you get the insulin injections. They're insulin dependent. Without insulin, the patient will develop diabetic ketoacidosis, also known as DKA, a life-threatening condition resulting in metabolic acidosis. Remember I told you back when you were doing the fluid and electrolyte and we were doing some of these, the oxygenation, you're not done with the acidosis, the alkalosis part. Metabolic acidosis is a real big concern, especially with somebody that is a type 1 diabetic. Patients with newly diagnosed type 1 diabetes may experience a remission or honeymoon period for 3 to 12 months after treatment is initiated. During this time, the patient requires very little injected insulin because the B cell insulin production remains sufficient for healthy blood glucose levels. But eventually, as more B cells are destroyed by the virus, or whatever is killing them, and blood glucose levels increase, the honeymoon period ends, and the patient will require insulin on a permanent basis. This is why sometimes you will see people starting out will maybe be started on a sliding scale insulin. They won't be started, they won't be started maybe like on 10 units of Humulog. They may be started on, okay, when your blood sugar, when you take it, is 180, give yourself 2 units of insulin. So they may not need that all the time because their blood glucose, when they're testing it, may not be that high. So that's what they're talking about when we talk about that. Okay, moving on to type 2 diabetes. This is formerly known as adult onset diabetes, or AODM, or more commonly non-insulin dependent diabetes mellitus, or NIDDM. Okay, so when we're looking at this one, this is type 2 is the one where you're going to see the oral medications as opposed to the insulin. All right, let's see. Type 2 diabetes mellitus is the most prevalent type of diabetes, accounting for over around 90 to 95% cases of diabetes. Being overweight, obese, advanced age, and having a family history of type 2 diabetes are some of the many risk factors contributing to the development of the disease. A lot of these, as you can see, obesity, being overweight are 2 risk factors. They're called what? Modifiable. You can deal with them. You can make the changes. Non-modifiable, unfortunately, is having a family history of it. Even though you can take precautions, you're going to still always have that, run that risk with it, okay? On that, an advanced age. You can't change your age no matter how much you want to. I would like to go back to 35, but there's no, I identify as a 35-year-old, and there's no way I can go back to that. So, once again, non-modifiable risk factors are your advanced age and your family history. Your modifiable are overweight and obesity. You can work on those. You can diet, you can exercise. There are things that you can do to change that part. Although the disease is seen less frequently in children, the incidence in children is increasing as a result in the increase of prevalence of childhood obesity. Prevalence of type 2 diabetes is greater in some ethnic populations, such as your African Americans, Asian Americans, Hispanics, Native Hawaiians, or other Pacific Islanders, and Native Americans. And that has a lot to do with, old family history, diet, maybe. So it might be a genetic thing with it on that. So if you look on page 1122, at the very top of it, it says Genetics and Clinical Practice, Type 1 and 2 Diabetes Mellitus. And MODY, don't worry about maturity onset diabetes of the young. We're not going to delve into that one. But look at your Type 1 and Type 2. Genetic basis on with Type 1, if you see it says increased susceptibility 40 to 50% when one has specific human leukocyte antigens, and it talks a little bit about that. And type 2 talks about polygenic genes. So if you're interested in a genetic part of it, this is kind of gives you an idea with it. The interesting thing of it is if you drop down to the middle section where it says risk to offspring, with type 1 diabetes, risk to offspring of mothers with diabetes is 1 to 4%. Risk of offspring of fathers with diabetes is 5 to 6%. It increases. And when one identical twin has type 1 diabetes, the other gets the disease about 30 to 40% of the time. So I do know, I have known several sets of identical twins, one of the siblings had diabetes type 1 and one did not have it. Did not have any diabetes at all with it. With that. So if you look over at type 2 under risk of offspring, risk to offspring is 8 to 14%. When one identical twin has type 2, the other gets it 60 to 75% of the time. So you can see with the identical twin that the risk is up higher. So same thing with it. It doesn't matter if it's mother or father. It's just the risk is greater with that. So like I said, if you're really into the genetic part of it, this would be kind of breaks it down into a cool form for you. So looking at the pathophysiology of diabetes mellitus. You can find this on page 1122 in your textbook. So, in type 2 diabetes, the pancreas usually continues to produce some endogenous or self-made insulin. However, the body either does not produce enough to where it's even effective or does not use it in an effective manner, or it could be both of the reasons. The presence of endogenous insulin is a major distinction between type 1 and type 2. In type 1, remember, endogenous insulin is absent. This is why they require exogenous, outside source, why they require the insulin injections with it. Okay, now, continuing on with the etiology and pathophysiology, of diabetes type 2. Okay, metabolic abnormalities have a role in the development of type 2 diabetes. It is likely a multiple genes that have become involved with it. So, this is because insulin receptors are unresponsive to the action of insulin and are insufficient in number, meaning most insulin receptors are located in the skeletal muscle, fat, and liver cells. When insulin is not properly used, the entry of glucose into the cells is impeded, resulting in hyperglycemia. Remember, hyperglycemia is high glucose. In the early stages of insulin resistance, the pancreas responds to high blood glucose by producing or making greater amounts of insulin if the B cell is functioning correctly. This creates a temporary state of hyperinsulinemia that coexists with the hyperglycemia, which means it's just a high level of insulin that's coexisting with the high level of glucose. Then we're going to move on to 2, which is a decrease in the ability of the pancreas to produce insulin as the B cell becomes fatigued from the compensatory overproduction of insulin, or when B cells mass is lost. The underlying reason why the B cell is going to fail is to adapt is unknown. They don't know. They're still studying it. There's lots of studies still going on with it. It may be linked to an adverse effect of hyperglycemia that's going on chronically, or high levels of circulating free fatty acids. They're not real sure with it. In addition, the alpha cells of the pancreas increase production of the glucagon. So they're really not sure why. Note that they're just speculating at this point in time with it. 3 is inappropriate glucose production by the liver. And this is, instead of properly regulating the release of the glucose in response to the blood levels, the liver does so in a haphazard way, kind of like, I might not. It just doesn't, it might produce more insulin when you really don't need it, and just gives it a little bit of insulin when your blood sugars are really high. So it just kind of does what it wants with it. However, this is not considered a primary factor in the development of type 2. Just because the liver is doing what the liver wants to do does not mean that this is why you're getting type 2 diabetes with it. Number 4, altered production of hormones and cytokines by adipose tissue. The adipokines secreted by the adipose tissue appear to play a role with glucose and fat metabolism, and which are likely to contribute to the pathophysiology of the type 2 diabetes. They are thought to cause chronic inflammation, a factor involved in insulin resistance, and type 2 diabetes and cardiovascular disease. You see type 2 diabetes and cardiovascular disease linked together quite a bit. The 2 main adipokines believed to affect insulin sensitivity, adipectin and leptin. Don't worry about those. At this point in time, I'm not going to ask you them on the test, just flat out. Finally, the brain, kidneys, and gut. We're on number 5. Finally, the brain, kidneys, and gut also have roles in the development of type 2 diabetes, and scientists are continuously learning more about the metabolic factors in the development of type 2. So they kind of have an idea. They know that it's because it has to do with the, the production of insulin, and it's not being produced well with it, but it just kind of goes, pancreas is the key player in it. They just don't understand why it is happening when it does, or how it does. Okay, individuals with metabolic syndrome are at increased risk for the development of type 2 diabetes. 5 components characterize metabolic syndrome, which are elevated glucose levels, abdominal obesity, elevated blood pressure, high levels of triglycerides, and decreased levels of high-density lipoproteins, your HDLs. An increase with 3 of the 5 components is considered to have a metabolic syndrome. So in order to have metabolic syndrome, you need to have 3 of, not all of them, you have to have at least a minimum of 3 of these. So sometimes you might have abdominal obesity, elevated glucose levels, and maybe high levels of triglycerides, which puts you in the, you are considered now to have metabolic syndrome. Overweight individuals with metabolic syndrome can reduce their risk for diabetes through a program of weight loss and regular physical activity with it. So we're looking at some of it is going to be, all of these are modifiable. You can change your triglycerides and your HDLs. You can bring your glucose levels down. So these are all things that you can change, which make them modifiable risk factors. Okay, type 2 diabetes onset of the disease. It's gradual onset. Patients may go for many years with undetected hyperglycemia. That's why when I first talked about the statistical information, when I was talking about like the 100 and some thousand people that have diabetes but do not know it, because it's asymptomatic a lot of times, or it's a gradual onset with it. They may not have any symptoms until they go in and have some blood work done. Many people are diagnosed on routine laboratory testing or when patients undergo treatment for other conditions, and elevated glucose or hemoglobin A1C levels are found. They also call it HA1C levels with it. The signs and symptoms of hyperglycemia develop when about 50 to 80% of the beta cells are no longer secreting insulin. So you can, like I said, you can go on and have this for years and not really show anything until, maybe you go in and you've got a wound that's not healing, or you go in for an annual checkup and you're 45 years old or something along those lines, and they do some blood work and, your glucose levels are elevated. Let's do an A1C, HA1C on you, and let's do some other blood work and let's see what's going on. At the time of diagnosis, the person has had type 2 diabetes for at least 6.5 years. Kind of scary if you stop and think about it. Which brings us to prediabetes, which can be found on page 1123 in your textbook. What this means is you have a high increased risk for developing type 2 diabetes. So individuals diagnosed with prediabetes are at increased risk for development of it. Prediabetes is defined as an impaired glucose tolerance, impaired fasting glucose, or both. So you're going to have an impairment of glucose tolerance, maybe I can remember when I had to do this for glucose tolerance when I was pregnant with it. So they do that testing with it, or an impaired fasting glucose, or both, or you can have a combination of both. So there's some tests. It's just not a one-time glucose level of 180 saying, oh, you're this. It's going to take a little bit of testing with it, and these are some of the tests that they're going to do to see if you have type 2. It is an intermediate stage between normal glucose homeostasis and diabetes, where the blood glucose levels are elevated but not high enough to meet the diagnostic criteria for to be a diabetic. A diagnosis of an IGT, or an impaired glucose tolerance, is made if the 2-hour glucose tolerance test values are 140 to 199. The IFG, which is known as the impaired fasting glucose, is diagnosed when the fasting glucose levels for this test are between 100 to 125. No, you're not going to have to know these levels on the test. You do need to know, you might need to know later on, maybe with maternal child, especially the impaired glucose tolerance with it. But just know that for prediabetes, for them to be considered that, they're going to probably run the impaired glucose tolerance test or an impaired fasting glucose test to see if they really do follow into what the prediabetic category. So prediabetes, they're asymptomatic, but long-term damage is already occurring. So that means that their glucose levels are elevated, but remember, not enough to consider them diabetic yet, but even if they're elevated, they're still causing damage with it. So persons with prediabetes, remember, usually do not have symptoms. They don't have the frequent urination, frequent hunger, or whatever, but they're already having the damage done. Maybe they might have frequent urination the little bit closer they get to the higher levels, but not always. It is important for patients to undergo screening and to understand risk factors for diabetes. Patients with prediabetes can take action to prevent or delay the development of type 2. Encourage those with prediabetes to have their blood glucose and A1Cs checked regularly and monitor for symptoms of diabetes such as polyuria, polyphagia, and polydipsia. Remember, you need to know those words. Maintaining a healthy weight, exercising regularly, and making healthy food choices have all been found to reduce the risk of developing overt diabetes in people with prediabetes. So basically, this is where you're going to do your patient education, change your diet, exercise, cut back on your carbs, not get rid of them, but cut back on your carbs with it, cut your proteins down a little bit, limit your size portions, don't go for the the extra large drinks, get rid of your pops, whatever. So this is where you're also bringing in a dietitian with it. But pre-diabetes, these are where you're going after your modifiable risk factors to help you, reduce your chances or reduce their chances of getting diabetes. Okay, just going to touch ever so briefly on gestational diabetes, which can be found on 1123. Gestational diabetes develops during pregnancy and occurs in 4.6 to 9.2% of the pregnancies in the United States. Women with gestational diabetes are at higher risk of needing cesarean delivery, and their babies have increased risk for prenatal death, birth injury, and neonatal complications. Women who are at high risk for gestational diabetes are screened at the first prenatal visit. Those at high risk include women who are obese or advanced of maternal age, advanced maternal age, and have a family history of diabetes. Women with an average risk of gestational diabetes are screened with the OGTT, oral glucose tolerance test, remember, at 24 to 28 weeks gestation. Most women with gestational diabetes have normal glucose levels within 6 weeks postpartum. Be aware that women with a history of gestational diabetes have up to a 63% chance at developing type 2 diabetes within 16 years. So like I said, they are at a higher risk. They are at a 63% chance of developing type 2 diabetes within 16 years of being diagnosed with gestational diabetes with that. Okay, clinical manifestations of type 1, you can find those on page 1124 in your textbook. And because type 1 is such a rapid onset, initial manifestations are usually acute. It's going to be just kind of like, boom, there it is. The classic symptoms are going to be your polyuria, polydipsia, and your polyphagia. And this is due to the osmotic effect of the glucose and what happens when it produces just basically the osmotic effect of glucose, which produces a manifestation of the excessive thirst and excessive frequent urination with that. Remember, osmotic is a kind of a release of the water. Polyphagia is a consequence of cellular malnourishment. The cells are hungry, so they're not getting the nutrition that they need, so they're constantly trying to make up for it, and so you're constantly eating with it. Weight loss may occur because the body cannot get glucose and turns to other energy sources such as fat and protein. The body kind of turns on itself, so the stores that we have for areas of, for times of starvation, fasting or whatever, the body is eating away our reserves with it on that. Here is just a little mnemonic that maybe will help you with understanding kind of the signs and symptoms of type 1 diabetes. Okay. Type 2 diabetes, clinical manifestations can be found in 1124. They have very non-specific symptoms with it. So the clinical manifestations of type 2, like I said, are very non-specific with it. Although it is possible that an individual with type 2 will experience some of the classic symptoms associated with type 1 diabetes, including polyuria, the thirst, the hunger, the urination. Some of the more common manifestations associated with type diabetes are going to be more along the lines of fatigue, recurrent infection, recurrent vaginal yeast or candidal infections like thrush, prolonged wound healing, and visual changes. Usually visual changes might be the key factor. You might go to your yearly eye exam and you've just got these changes, and they've got a way of telling, okay, you've got some visual changes that we only see with diabetic people. You need to go in and be checked with it. And prolonged wound healing are the two things that you probably will see the most commonly leading into, okay, I need to go see the doctor about this. Okay, just another mnemonic with about type 2 diabetes. If any of these pictures that I post on these PowerPoints don't show up very well and stuff, and you would like to see some see them, you know, in a different format or a little bit bigger, I can make them bigger for you and just post them for you. Just let me know. Just shoot me an email and tell me, and I'll take care of that for you. Okay, diagnostic studies found on page 1124 in your textbook. The diagnosis of diabetes is made using one of four methods. These methods and their criteria for, you know, are used either altogether or separately, but typically they're going to use these methods in a combination of maybe at least one or two of them to help with the diagnosis of diabetes. Your hemoglobin A1C level is going to be 6.5% or higher. You're going to do a fasting plasma glucose, and the level will be 126 milligrams per deciliter or higher. Now remember, with fasting, that means nothing with calories 8 hours prior to the testing. But they can have water to help swallow their pills, but other than that, they can't have anything 8 hours prior to it. 2-hour plasma glucose level, that's going to be 200 milligrams per deciliter or higher. And then your classic symptoms, they're going to present with classic symptoms of hyperglycemia with random plasma glucose levels of 200 milligrams per deciliter or higher. So when we're looking at it, the A1C is going to be is the one that they're going to use the most, and it's going to be the most commonly one. What it is looking at is, and the nice thing about the A1C is, one, it does not have to be fasting, and two, it looks over a period of time with it. So what the A1C is doing is it is measuring the amount of glycosylated hemoglobin as a percentage of the total of hemoglobin. Basically, it's saying if the hemoglobin A1C is at like 7.5%, that means that 7.5% of the total hemoglobin has glucose attached to it. So it's just looking at it. Just remember, the A1C is just looking at the percentage of total hemoglobin that has glucose attached to it. The amount of hemoglobin that is glycosylated depends on the blood glucose level. So when the blood glucose level are elevated over time, the amount of glucose attached to the hemoglobin molecules increases. So this is why this is a really good example of seeing how somebody's levels are doing, and this is why they use it a lot, because it gives them a picture of what is going on. It looks at a picture of the blood, what the person's glucose levels have been doing over the past 3 months. So it looks at a period of 2 to 3 months, where your fasting is only looking at the past 24 hours, 12 to 24 hours. It's looking at the now, where the A1C is looking at the whole picture of what your glucose level has been doing. Okay, the goals of diabetes management are to reduce symptoms, promote well-being, prevent acute complications related to hyper or hypoglycemia, and to prevent or delay the onset and progression of long-term complications. The goals are more likely to be met when the patient is able to maintain blood glucose levels as near as normal as possible. So there's going to be a constant, continual education and working with the patient to make sure that they're meeting their goals with it. Okay, remember, diabetes is a chronic disease that requires daily decisions about food intake, blood glucose monitoring, medication, and exercise. So one of the things that's going to be a big factor is patient teaching. So patient teaching is going to enable the patients to become the most active participant in his or her own care. Is essential for a successful treatment plan. So you're going to make sure that they get nutritional therapy, they have an understanding if they're having problems with it, especially if they're no diabetic, hook them up with a registered dietitian. Drug therapy, you're going to be doing a lot of education with them. Also, you know, the pharmacist is going to be working with them on that. So there is a lot of education that's going to be going on with it. Exercise is very important. Self-monitoring of blood glucose levels are tools that are used in the management of it. So you're going to be educating them. So if you have a chance to work with them, if you become a diabetic educator, or you have a chance to refer somebody to the diabetic educator at the hospital or the clinic or whatever, go in and sit with them and see what some of the ideas are, because they've got ideas that maybe we don't think of. And one of the most important things that I've talked to with some of the patients is glucometers. Glucometers are different. Some require that you check the glucose, you check it to make sure that the glucose machine is registering, the glucometer, is registering correctly. Some of them don't require. Some of them require a lot of blood. Some of them don't require blood. Some of them require special strips. It gets very confusing with your glucose monitors with it. So be sure that, you sit down with them and they know. If they have a problem with it, they can ask a pharmacist. The pharmacist also can help them with it. So, but just tell them, let them know that they have resources out there. Even your local health department can help them with the glucose monitors. And that seems to be the biggest struggle for them. So, for some people with type 2 diabetes, a healthy eating plan and regular physical activity and maintenance of a healthy body weight are sufficient to attain an optimal level of blood glucose levels. However, sometimes it doesn't work. So drug therapy is necessary because diabetes is a progressive disease, remember. So if exercise and diet isn't working, then they're going to end up putting them on some medication. The major types of glucose-lowering agents, you'll see it as GLAs, used in treatment of diabetes are insulin and oral agents, and non-insulin injectable agents. All individuals with type 1 are going to require insulin. Remember that. Okay, we're just going to go quickly. We're not going to delve too much into this and stuff. I don't want you to focus too much on individual ones with it. Just want you to have an understanding about what we're going to talk about with this, and we'll delve more into the actions and stuff of it when we talk in pharmacology. So oral agents work on 3 defects of type 2 diabetes: insulin resistance, decreased insulin production, increased hepatic glucose production, and can be used in combination. Oral agents and non-insulin injectable agents work to improve the mechanisms by which the insulin and glucose are produced and used by the body. These drugs work on 3 defects of type 2 diabetes: insulin resistance, like I said. So they're going to work maybe on the help with the insulin resistance, decrease insulin production. They're going to also help, they just will work on a combination of things with it. The goal is to achieve a good blood glucose level. Type 1 diabetics require exogenous insulin to survive and may need to have multiple daily injections of insulin. As you've seen on clinical rounds of stuff, you've got people that are getting it up to 4 or 5 times a day, or they might have it through a continuous infusion, like through an insulin pump with that. So when we talk about exogenous insulin, we're talking about insulin that is injected. It's from, it's not being made inside the body. It's something that has been manufactured, and we are injecting it into our body with it. It's basically from an outside source with it. It's required for type 1 diabetics. It may also be prescribed for patients with type 2 diabetes who cannot manage their blood glucose without the extra assistance with it. Sometimes you'll see that type 2 diabetics will have it if they have been sick, if they've been hospitalized and they've had like pneumonia, they've had an infection, and their oral medications are no longer keeping their blood glucose levels down. So today, only genetically engineered insulin is being made in laboratories. The insulin is derived from common bacteria, such as like E. coli or yeast cells, throughout recombinant DNA technology. In the past, insulin was extracted from the pancreas of beef or pork. When I graduated nursing school in '96, we were still using pork insulin a little bit. There were problems with it. People would have more reactions with it. So this is why, the shelf life of it wasn't very long, and it was expensive. So they kind of have gotten away from that. Insulins that were made from the pancreas of a cow or a pig are no longer made. So you don't have to worry about it. That's kind of like a little sidebar thing with it. Insulin differs by their onset, peak, action, and duration, and are categorized as rapid acting, short acting, intermediate acting, and long acting insulins. we'll get into the details of, which ones are which. I did include, a little bit of brief of what it is, in here, so you kind of have an understanding of it. But when we get into pharmacology, we'll really look at the insulins with it. The base of all insulin preparations is regular insulin, and the onset of the activity, peak, and duration times are manipulated by adding zinc, acetate buffers, and protamine. The zinc and protamine added to make intermediate acting NPH, and the problem with this is if you have a allergic reaction, like maybe allergy to zinc, it may cause like an allergic reaction at the injection site with it. This slide, you do need to be familiar with it, so I did put this on there and stuff. You do need to know which ones are long acting, which ones are short acting, which is regular. This shows you when it starts to work, peak action, for how long, duration of action, and maximum duration of action. This is also an insulin cheat sheet that I found that I gave last year for students in class boards. So if you do need to become familiar with it on this, especially now that you're starting to give insulins and stuff on your clinical patients, and especially starting next semester when you do clinicals and stuff, you do need to know why a lot of times we have patients in the hospital, they get their finger sticks done, they're waiting for breakfast, and we don't give them their insulin because a lot of times you don't want to give them insulin, and Humalog is the most commonly one. It starts to work in 30 minutes and it's bringing the blood sugar down, and the breakfast tray is an hour and a half late getting there. So you want to make sure that they're eating when you give them the insulin, so that way they're getting their food in there and stuff, so there isn't that chance of going hypoglycemic on you. Okay, so with this one on this slide, this just gives you kind of a idea of kind of what the basal bolus regimen is, or mealtime insulin is. It just kind of shows you some of the different ways that they do it. The basal bolus one is probably the most commonly one. It mimics closely to what the body is doing with it. So it looks like giving rapid or short acting insulin before meals, and then intermediate or long acting insulin once or twice a day. And usually it's just once a day. Sometimes it'll be twice a day, but typically it is given once a day with it. Now sometimes you will have patients that will just get insulin at mealtime. So they might get the rapid, the insulin like Lispro with it, or they might get, Humulin with it. So it's just kind of one of those. It's just kind of give you an idea of why they do certain things with it. Like I said, it all goes back to, you do need to know rapid acting insulin, which is Humalog, which is your most commonly used one. It should be injected. It said the literature and stuff says should be injected within 15 minutes of meal times, but a lot of times, because especially like in a hospital and stuff, where the meals depend on somebody else getting them there, it's a lot of places, 15 minutes before meal times, but a lot of places the nurses will give it when they see the trays up there on the floor, because they want to make sure that they've got the trays, and then they can give the insulin, because it's really bad if you give the insulin and the trays are like an hour and a half late. Then you've got a bunch of diabetics that are having possible issues, so you have to find crackers and something for them to snack on with that. So basal background insulin is, in addition to mealtime insulin, people with type 1 diabetes use a longer acting basal or intermediate acting background insulin to maintain the blood glucose levels between the meals and overnight. Levemir and Lantus are your two commonly used ones that they use with it. Because they lack peak action time, the risk for hypoglycemia from this type of insulin is greatly reduced. It's more of a steady consistency with it. So intermediate action NPH, is also used as a basal insulin. Its action has a duration of 12 to 18 hours with it. Like I said, Levemir and Lantus are your two commonly used ones that you're going to see with it. Okay, just a reminder, if you're having to do that, remember you're going to draw up clear first. Remember you're going to figure out how much insulin for both doses you're going to be pulling up, insulins you're going to be pulling up, and you're going to inject them in the bottles. Be sure you draw up clear before cloudy. So clear to, think of a weather forecast. You're going to go from clear to partly cloudy with it. Okay, this one's a refresher course from when you did just drew a blank. Your med administration. So administration of insulin absorption is faster from abdomen, followed by arm, thigh, and buttocks. Abdomen is often preferred site. It's easier to access. It's easier for the patient to inject themselves. Do not inject in site to be exercised. So if you're going to, they're a young person and they're going to be doing, bicep curls and exercising, you don't want them to do it in their arm. The abdomen's going to be a lot easier. Rotate injection sites within and between the sites. So just like we said, you're just going to start in one quadrant and just kind of work your way around, because you don't inject in a bruise either with that. An insulin pump delivers a continuous subcutaneous insulin infusion through a small device worn on a belt or in a pocket under clothing. Insulin pumps use rapid-acting insulin, which is loaded into a reservoir or a cartridge and connected via plastic tubing to a catheter that is inserted into the subcutaneous tissue. All insulin pumps are programmed to deliver a continuous infusion of rapid-acting insulin 24 hours a day, and this is known as your basal rate. The basal insulin can be temporarily increased or decreased based on patient need. Excuse me. All insulin pumps, like I said, are pre-programmed. The doctor will program them so that they're just set to deliver a certain amount of insulin over a continuous period of time. With that, at mealtime, the user programs the pump to deliver a bolus infusion of insulin appropriate to the amount of carbohydrates ingested and an additional amount if needed to bring down or correct high preprandial blood glucose levels. Monitoring 8 times or more per day is common. A major advantage of the insulin pump is the potential for keeping blood glucose levels in a tight range, and this is possible because the insulin delivery becomes very similar to the normal physiological pattern. So you see this a lot, especially in younger people, because they're very busy and stuff, and it just makes it easier for them to manage their diabetes. So the American guideline has set out some guidelines, and it used to be they had to be a really strict, 1,400 calorie ADA diet. And so they have changed. It's become more of basically a liberalized type diet with it. So they're basically saying that a person with diabetes can eat the same type of stuff that a healthy person does. It's just making smart choices. You just need to look at foods that are going to help you maintain your blood glucose levels as close to normal, achieve lipid profiles and blood pressure levels that reduce the risk for cardiovascular disease, prevent or slow the rate of development of chronic complications, address you're going to address individual needs. Look at what they want to eat, what they like and stuff. It is basically, trying to help them maintain, the pleasure of eating and help them maintain a normal life as possible with it. So it's not near as rigid as it used to be. So the thing about with nutritional therapy with diabetes type 1 is meal planning based on usual food intake and preferences balanced with insulin and exercise patterns. Day-to-day consistency is very important, makes it easier to manage blood glucose levels, and more flexibility with rapid-acting insulin, multiple daily injections, and insulin pump with it. So basically, they're going to learn how to control their diet. I've known some diabetics, I've taken care of them over the years, that they'll eat what they want, then they'll take their finger sticks and they'll do their insulin and adjust it that way, which is not a good way to go, because a lot of times some of them, their blood sugars are like 400 and then they're taking all that insulin. It's just not a good thing. It's just better to try to control it before you start eating all the, sitting down and eating a large supreme pizza by yourself with it. So that's where, nutritional therapy comes very handy in helping them learn to cope with their disease. So nutritional therapy with type 2 is geared for emphasis on achieving your glucose, lipid, and blood pressure goals, making sure, your blood pressure gets low, your glucose levels are where they need to be, weight loss. You're going to, be sure that with the nutritional is an adequate meal plan, several meals, maybe small meals a day, instead of eating one large meal a day. You're going to have decreased fat and decreased carbohydrates. You're going to, exercise regularly. So these are things that you want to help them. It'll help them lose weight, which will help maybe reduce their risk or their need for diabetic medications. So they even say a weight loss of 5 to 7% of body weight often improves blood glucose levels, even if desirable body weight has not been achieved. So if the person is morbidly obese, if you can get them to lose 5 to 7% of the body weight, it will help them in the long run with it. So, what do they need to have? Carbohydrates, there need to be a minimum of 130 grams per day. Fruits, vegetables, whole grains, legumes, low-fat dairy. All benefits from include, you need fiber. It helps pull out the bad cholesterol. It helps keep your bowels normal. So, dietary fiber is very, very important with that. Let's see. The current recommendations in general for dietary fiber is 25 to 30 grams per day with it. So play around with it, read your labels. You're going to teach them how to read the labels and understand that. Nutritive and non-nutritive sweeteners may be included in a healthy meal plan in moderation. So when we're looking at the non-nutritive sweeteners, they include sugar substitutes, saccharin, which they don't do anymore, aspartame, sucralose, neotame. Aspartame is probably the most commonly used one that I can think of right now with it. Some people can't tolerate it, so they have to figure out one of the others. Sucralose is probably another one that they could use with it. Dietary fat provides energy, carries fat-soluble vitamins, and provides fatty acids. The ADA recommends limiting saturated fats to probably around 7% or less of the calories, and then less than 200 milligrams a day of cholesterol and limited trans fats are recommended. So your fat is going to be where you really probably want to concentrate on more than with your carbohydrates with it. Although carbohydrates do cause problems, just limiting both of them is a very good idea. Okay, protein should make up to 15 to 20% of your total calories. High protein diets are not recommended. You want to break it down, so you really want to keep it really no more than 20% of your daily dietary intake with that. So high protein diets are not recommended for weight loss for people with diabetes, just because of the way the system works, the body works, and how it reacts with the glucose and stuff. So the ADA recommends 15 to 20% of total calorie be of protein. Alcohol, limit to moderate amount, 1 drink per day for women, 2 drinks per day for men with it. So just drink in moderation, because all alcohol does have a high level of sugar in it, some form or another, especially like wines and stuff like that. So that's why they usually say limit for women one drink per day and 2 drinks per day for men. So this is why I stress that if you have somebody that's a newly diabetic, is having issues with controlling their diabetes, get them a dietitian, because there's a lot of stuff to try to remember with dietary needs and stuff with it. So dietitian initially will provide the instructions with it, kind of give them a guideline of, you need to have so many servings of carbohydrates per meal. Insulin dose based on on carbohydrate consumed, which you see with insulin pumps and stuff like that. So typically what they say is a serving size of carbohydrate is 15 grams. A typical adult usually will start with 45 to 60 grams of carbohydrates per meal. For some patients, insulin doses are tailored to the number of carbohydrates a patient will consume at the meal, with a set number of units of insulin given per every 15 grams of carbohydrates, or sometimes another number. So you need to teach the patient about foods that contain carbohydrates and how to read food labels and appropriate serving sizes. But this is again why I strongly recommend that you get a dietitian involved in the middle of this, because it's just, there's a lot of information and they can answer questions about carbohydrates and stuff maybe better than you can as a nurse. Okay, exchange lists. This is diabetes exchange lists are another method for meal planning. Instead of counting carbohydrates, the individual is given a meal plan with specific numbers of helpings from a list of exchange foods for each meal and snack. The exchanges are starches, fruits, meat, vegetables, fats, and free foods. The patient chooses foods from the various exchanges based on the prescribed meal plan. The method may be easier for some patients than others. So this may be something that you will see some patients with. I've seen some patients with it. Some patients do really good. Some patients struggle and don't follow this one very well. When possible, include family members and caregivers in nutritional education and counseling. It's very important that from the get-go, everybody involved with this patient needs to be educated so they know. So they're not sitting there sitting in front of this family member eating a large blizzard in front of this patient that can't have that. It's not fair. It's kind of like the equivalence of sitting there telling the kid he can't eat a bowl of ice cream, but you're sitting there eating that bowl of ice cream in front of that child. It's just not a fair thing. So it works to the benefit of the family if they're all on board with this type of diet. So it helps the patient stay consistent and stay compliant with the diet. Now, not everybody is going to be that way, but it's helpful if everybody's all on the same page. So the compliance is there. Exercise. Type and amount of exercise is regular, consistent exercise is an essential part of diabetes and pre-diabetes management. That it is recommended by the ADA that people with diabetes will engage in 150 minutes per week, which is 30 minutes per 5 days of a moderate intensity aerobic physical activity. They encourage people with type 2 diabetes to perform resistance training 3 times a week in the absence of contraindications, which means they don't have a hip fracture and they can't do squats or whatever with it. That's what we're talking about. They also encourage people with to exercise regularly. Like I said, exercise will decrease insulin resistance and can have a direct effect on lowering blood glucose levels. The therapeutic benefits of regular physical activity may result in decreased need for diabetic medication in order to reach the target glucose levels. With it, as always, if they've not been active and they're sedentary, please encourage them to start slowly and start simply. Self-monitoring of blood glucose enables decision regarding diet, exercise, and medication. You see it a lot with type 1 diabetics. Type 2s will do it not near as frequently. Type 1, remember, they're the insulin dependent, so they're needing to do it very frequently, at least 4 times a day, to monitor their blood glucose levels to see if they maybe need to take some extra insulin with it. Type 2 diabetics may take their finger sticks maybe once a day, twice a day, once a week, just kind of really depending on the plan that they've come up with their doctor, because their pancreas, remember, is still producing a little bit of insulin, and they're taking medications to kind of help boost it. So it's not really as important for them to take their finger sticks just as as frequently as somebody on insulin. So with this one, with patient education, you're going to teach them how to use it, how to calibrate it, when to test, before meals, 2 hours after meals, when hypoglycemia is suspected, during illness, before and during and after exercise. It's very important that they do, know how to use it. Excuse me. So, like I said, somebody that's newly diabetic, you're going to do a lot of teaching with it, because you want to make sure that they have an understanding of when to take it, how to interpret their readings with it. It's also important that They understand how to check this, do the control solutions. Some of them, I've seen them to where they don't have to do the control solution with it at all. So, be sure they have an understanding, and it's a glucometer that they know how to use. I mean, there is a lot of them out there, so there's just kind of whatever works for them. They do have really cool ones that will talk to them, say, it's ready for the drop of blood. It will say the reading out loud. So just kind of find one that is going to really work the best for your patient with it. Okay, one of the things with patient education that you're going to need to do with your diabetics is you're going to need to teach them, what to do, what to look for, what are their process going to be if they start noticing that their blood glucose is starting to elevate and they're feeling sick. The doctor's may sometimes with the patient say, okay, so if you notice this, take a couple extra units of insulin, call and get into the doctor. If it typically runs like 110 and it's up to 150, get into the clinic as soon as you can. If it goes up to 200, get into the ER. So the doctor is going to already have that plan with the patient. So you're going to need to make sure that they maintain a normal diet as able. If they can't keep anything down and they're vomiting and stuff, they're going to need to know that maybe they need to hold their insulin. So there's a lot of steps that go into this, but the biggest thing is there needs to be that line of communication between the diabetic's family, and the provider on that one. And remind them that if they start a steroid, their finger sticks are going to go up, their finger stick readings are going to go up. So the doctor may have them do a sliding scale if they didn't do a sliding scale before, because their glucose levels are so elevated during that time with that steroid medication. Okay, diabetic ketoacidosis is caused by a profound deficiency of insulin and is characterized by hyperglycemia, ketosis, acidosis, and dehydration. It is most likely to occur in people with type 1, but may be seen in people with type 2. Especially if they have a condition where there's been like severe illness or stress when the pancreas cannot meet the extra demand for insulin. So some of the precipitating factors or factors that occur that lead up to it include illness and infection, inadequate insulin dosage, undiagnosed type 1 diabetes, poor self-management, and neglect. So when the circulating, this little mnemonic kind of shows you what ketoacidosis is all about. So when the circulating supply of insulin is insufficient, glucose cannot be properly used for energy. The body compensates by breaking down fat stores as a secondary source of fuel. Ketones are acidic byproducts of fat metabolism that can cause serious problems when they become excessive in the blood. Ketosis alters the pH balance, causing metabolic acidosis to develop. Ketonuria is a process that occurs when the ketone bodies are excreted in the urine. During this process, electrolytes become depleted as cations are eliminated along with anionic ketones in an attempt to maintain electrical neutrality. Insulin deficiency impairs protein synthesis and causes excessive protein degradation. This results in nitrogen losses from the tissue. Insulin deficiency also stimulates the production of glucose from amino acids in the liver and leads to further hyperglycemia. Because there is a deficiency of insulin, the additional glucose cannot be used and the blood glucose level rises further, adding to the osmotic diuresis. If not treated, the patient will develop severe depletion of sodium, potassium, chloride, magnesium, and phosphate. Vomiting caused by the acidosis results in more fluids and electrolyte loss. Eventually, hypovolemia will ensue and be followed by shock. Renal failure, which may eventually initially occur from hypovolemic shock causes the retention of ketones and glucose, and the acidosis progresses. Untreated, the patient becomes comatose as a result of dehydration, electrolyte imbalance, and acidosis. If the condition is not treated, death is inevitable. So time is very important with this. As you can see in the picture, onset over 4 to 10 hours. So it's very important that you start, recognizing kind of some of them. This is why if they're suspecting that they do a urinalysis to see if there are any ketones in the urine. So, with the clinical manifestations of DKA, dehydration occurs in DKA with manifestations of all classic signs and symptoms of dehydration: your poor skin turgor, your dry mucous membranes, tachycardia, and orthostatic hypotension. Early symptoms may include lethargy and weakness. As the patient becomes severely dehydrated, the skin will become dry. Remember, it gets that really dry, flaky look, and loose, and the eyes even become soft and sunken. Abdominal pain may be present and accompanied by anorexia, nausea, and vomiting. Kussmaul respirations, very important. DKA, Kussmaul respirations, which are rapid, deep breathing associated with dyspnea, are the body's attempt to reverse metabolic acidosis through the exhalation of excess carbon dioxide. Acetone is noted on the breath. This is where you get that fruit. You have somebody doing the Kussmaul respirations, and they also have a fruity odor to their breath. And that's because of the acetone that's in there. Laboratory findings that you're going to see are blood glucose levels of 250 or higher, arterial blood pH less than 7.3, sodium bicarb level less than 16, and moderate to tripping over my words today, and moderate to high ketone levels in the urine or serum with it. So your clinical manifestations, yes, are very important to know, especially the Kussmaul respirations, this acetone in the air, in the breath. So what are you going to do if you have somebody in DKA? You're going to establish patent airway, administer oxygen. Since it's a very serious condition that proceeds very rapidly, it must be treated promptly. So that's why if you notice somebody starting to show some of the signs, clinical manifestations or signs and symptoms, you want to make sure that you get them their oxygen. You make sure that their airway is okay, is patent. Ensure that you have maybe a non-rebreather mask, because you're going to get this. You want to recirculate that CO2. Because fluid imbalance is potentially life-threatening, the initial goal of therapy is to establish an IV access and begin fluid and electrolyte replacement. So this is something that if you see or might be suspecting of a nursing home patient, you will get them out of the nursing home and get them to the ER as soon as possible. The most common IV fluid that they're going to use is an infusion of 0.45% or 0.9% sodium chloride at a rate to restore urine output to 30 to 60 mL per hour to raise the blood pressure. Okay, so when the blood glucose level reaches 250, they're going to add 5 to 10% dextrose to the fluid regimen to prevent hypoglycemia, as well as a sudden drop in glucose. So they want to be very careful with it, so they don't want to really overhydrate them. So sometimes if they do rehydrate them with the hypertonic solutions, it'll cause cerebral edema. So this is why they want to do this very cautiously. So they're doing things quickly, rapidly, methodically, but they want to be careful with the rehydration because they don't want to cause a cerebral edema with it. You're going to measure serum potassium levels before starting insulin. If the patient is hypokalemic, insulin administration will further decrease the potassium levels. Make an early potassium replacement essential. So if they have low potassium levels, you're going to replace the potassium levels with potassium while you're giving the insulin, because remember, because insulin is going to cause problems further with the potassium depletion. So the big thing is IV administration therapy is directed toward correcting the hyperglycemia and hyperketonemia. So insulin is immediately started through a continuous infusion. They're going to maybe have potassium going also with it. It is important to prevent rapid drop in insulin serum glucose levels to prevent the cerebral edema. So they're going to do it, like I said, in slow increments with it. Insulin allows water and potassium to enter the cells along with glucose and can lead to depletion of vascular volume and hypokalemia. Therefore, you're going to monitor the patient's fluid balance and potassium levels very frequently. So you're going to see them get in labs drawn maybe every 1 to 2 hours to monitor that potassium level. Okay, so real fast on hyperosmolar hypoglycemic syndrome, HHS, which is found on 1145. This is the main difference between this and DKA is that the patient with HHS usually has enough circulating insulin so that the ketoacidosis does not occur. Because hyperosmolar hypoglycemic syndrome, also known as HHS, produces fewer symptoms in the earlier stages, blood glucose levels can climb quite high before the problem is recognized. The higher blood glucose levels increase serum osmolality and produces more severe neurogenic manifestations, which can cause either coma or seizures. Because the manifestations resemble a stroke, immediate determination of glucose level is critical for correct diagnosis and treatment. This is why when you do that, the stroke testing, you think somebody is having a stroke, you're checking to see what their glucose level is. Like DKA, HHS is a medical emergency and has a high mortality rate. The management of DKA and that of HHS are similar and include IV administration. HHS, though, usually will have greater volumes of fluid replacement, and this should be accomplished slowly and carefully. So with DKA, you're going to replenish supply of fluids, but at a different rate than HHS. With it, when glucose levels fall to approximately 250 milligrams per deciliter, IV fluids containing dextrose are administered to prevent hypoglycemia. You're going to assess vital signs, intake and output. You're going to be monitoring for any signs and symptoms of dehydration, cardiac monitoring. You're going to have them on a telemetry. You're going to be doing their labs, checking for, their serum osmolality and frequent assessments of their cardiac, renal, and mental status with it. So you're going to treat it similar to the DKA, but one of the other significant things about it is HHS, you may not have quite the problems with hypokalemia that you do with DKA in it. Okay, hypoglycemia or low blood glucose occurs when there is too much insulin in proportion to the available glucose in the blood, which then causes the blood glucose levels to drop to less than 70 milligrams per deciliter. When plasma glucose drops below 70 milligrams per deciliter, counter-regulatory hormones are released and the autonomic nervous system is activated. Suppression of insulin secretion and production of glucagon and epinephrine provide a defense against hypoglycemia. So when we're looking at this, epinephrine release causes manifestations that include shakiness, palpitations, nervousness, diaphoresis, anxiety, hunger, and pallor. So when you're starting to see certain signs and symptoms of hypoglycemia, this is because they have released the counter-regulatory hormones, which are part of the autonomics and the autonomic nervous system and the neuroendocrine hormones. So you've got all this stuff being released, which is causing, when you get to the next slide, we talk about, the common manifestations or signs and symptoms of hypoglycemia. Because the brain requires a constant supply of glucose in sufficient quantities to function properly, hypoglycemia can affect mental functioning. This is why when you see somebody that has low blood sugars, they're really not coherent. Their speech may be slurred. They may have visual disturbances with it. So this is why you see a lot of those changes when the blood sugars start getting lower. Untreated hypoglycemia can progress to a loss of consciousness, seizures, or coma. Hypoglycemia unawareness is a condition in which a person does not experience the warning signs and symptoms of hypoglycemia until the glucose levels reach the critical point. These are people that may become incoherent or combative or lose consciousness. This is because patients that are at risk for this are ones that have repeated episodes of hypoglycemia, or they may be older patients, or they may be taking medications that are blocking the release of the counter-regulatory hormones. So, treatment for hypoglycemia you're going to find on 1146 to 1147. They're going to follow the rules of 15 to treat hypoglycemia. So with that means a blood glucose level less than 70 is treated by ingesting 15 grams of a simple fast-acting carbohydrate, such as 4 to 6 ounces of fruit juice or regular soft drink. Commercial products such as gels or tablets containing specific amounts of glucose are convenient for carrying in a purse or pocket to be used in such situations. You're going to recheck the blood glucose level 15 minutes later. If the value is still less than 70, ingest 15 grams more of carbohydrates and recheck the blood glucose in 15 minutes. If there is no significant improvement in the patient's condition after 2 to 3 doses of 15 grams of simple carbohydrates, contact the healthcare provider. After an acute episode of hypoglycemia, have the patient ingest a complex carbohydrate after recovery to prevent repeat hypoglycemia. Avoid treatment with carbohydrates that contain fat, such as candy bars, cookies, whole milk, and ice cream. The fat in these foods will slow down the absorption of the sugar and delay the response to treatment. Avoid over-treatment with large quantities of quick-acting carbohydrates so that a rapid fluctuation of hyperglycemia does not occur. So that's why a lot of protocols will say either do the glucose or they will give them orange juice. So treatment in acute care settings is 50% dextrose, 20 to 50 mils IV push. Patients not alert enough to swallow, they're going to do the glucagon 1 milligram IM or subcutaneously. Explore reasons why this occurs with it. So the acute care setting, so you're going to follow what your facility protocol is with what you're going to do with hypoglycemia. So go back to your facility and find out what their hypoglycemic protocol is and become familiar with it. Here's a little mnemonic that kind of shows you about hypoglycemia. Okay, hyperglycemia is the opposite of hypoglycemia, which is low blood sugar. This is an elevation of blood glucose concentration above the normal range. This is high blood sugar. It is in the laboratory finding that establishes a diagnosis of diabetes mellitus. Hyperglycemia results from a decrease in the body's ability to utilize or store glucose after carbohydrates are ingested, and from an increase in the production of glucose by the liver during the intervals between meals. It is caused by a decrease in the production of insulin, a decrease in the action of insulin, or a combination of the two abnormalities. Mild hyperglycemia causes no symptoms, but more severe hyperglycemia causes an increase in urine volume and thirst, fatigue and weakness, and increased susceptibility to infection. Extremely high blood glucose concentrations result in loss of blood volume, low blood pressure, and impaired central nervous system function, which is also referred to as hyperglycemic coma. Okay, so we're going to talk just briefly about angiopathy, which is found on page 1147. This is one of the leading causes of diabetes-related deaths. Approximately 68% of deaths are due to cardiovascular disease and 16% due to strokes in patients aged 65 and older. Damage to blood vessels secondary to chronic hyperglycemia is one of the causes. Leading causes, like I said, cause of diabetes-related deaths. It's talks about the chronic blood vessel dysfunctions are divided, like I said, microvascular complications and macrovascular complications. There is a diabetes control and complications trial, and this is a landmark study in diabetes management demonstrating that patients with type 1 diabetes, the risk for microvascular complications could be significantly reduced by keeping blood glucose levels as near to normal as possible. So basically what they're saying, what this trial is saying is they're looking at people with type 1 diabetes and that are at risk for microvascular complications. They can, if they keep a better control of their blood glucose levels, they stand to improve their risks of any complications through microvascular complications with it. So it just was a little bit of a study on that one. So okay, chronic complications. This has got it broke up. This slide has got it broke up into macrovascular angiopathy and microvascular. So macro, you can look, complications or diseases of the large and medium-sized blood vessels that occur with greater frequency and with an earlier onset in people with diabetes. Macrovascular diseases include a CVA, cardiovascular, and peripheral vascular diseases. Remember, those are the ones that are going after your large and medium vessels. Patients with diabetes can decrease several risk factors associated with macrovascular complications such as obesity, smoking, hypertension, high fat intake, sedentary lifestyle. Smoking, which is detrimental to health in general, is especially injurious to patients with diabetes and significantly increases their risk for blood vessels and cardiovascular disease, stroke, and lower extremity amputation. The American Diabetic Association recommends yearly screening for the CVD risk factors in people with diabetes. So the main thing is you're going to optimize blood pressure control in patients with diabetes. You're going to try to help reduce their risk for cardiovascular disease. Microvascular complications result from thickening of the vessel membranes in the capillaries and arterioles in response to conditions of chronic hyperglycemia. They differ from the macrovascular complications in that they are specific to diabetes. Although microangiopathy can be found throughout the body, the areas most affected are the eyes through retinopathy, the kidneys through nephropathy, and the skin, which is dermopathy. Microvascular changes are present in some patients with type 2 at the time of diagnosis. However, clinical manifestations usually aren't going to appear for 10 to 20 years later. So remember, macro is going to be your larger vessels, your medium to your large to medium-sized blood vessels, and your macro is going to be thickening of vessels, membranes in the capillaries and arterioles. So you're thinking micro, you're going to think about eyes, you're going to think about retinopathy, you're going to think about nephropathy, kidney problems with the microvascular. Diabetic retinopathy refers to the process of microvascular damage to the retina as a result of chronic hyperglycemia, presence of nephropathy, and hypertension in patients with diabetes. It is classified as either non-proliferative, which is the most common, or proliferative, which is the most severe. And is estimated to, diabetic retinopathy is estimated to be the most common cause of new cases of adult blindness. Okay, diabetic retinopathy. It refers to the process of microvascular damage to the retina as a result of chronic hyperglycemia, presence of nephropathy, problems with the kidneys, and hypertension in patients with diabetes. Diabetic retinopathy is estimated to be the most common cause of new cases of adult blindness. It is also classified as non-proliferative and proliferative. So when we're talking about non-proliferative and proliferative, the most, which is non-proliferative retinopathy, is the most common form, And this is where there's a partial occlusion of the small blood vessels in the retina, which causes microaneurysms to develop in the capillary walls. These walls of the microaneurysm are so weak that the capillary fluid leaks out, causing retinal edema, and eventually heart exudates, and eventually intraretinal hemorrhage. Proliferative retinopathy, the most severe form, involves the retina and vitreous, and when the retinal capillaries become occluded, the body compensates by forming new blood vessels to supply the retina with blood. This causes a pathologic process known as neovascularization. These new vessels are extremely fragile and hemorrhage easily, producing vitreous contraction. Eventually, light is prevented from reaching the retina, and the vessels become torn and bleed into the vitreous cavity. The patient sees black or red spots or lines if these new blood vessels pull from the retina, while the vitreous contracts, causing a tear. Partial or complete retinal detachment will occur. If the macula is involved, vision is lost. So, like I said, the non-proliferative is really the most common, but it's not to say that proliferative won't happen. It's the most severe. This is where the person typically will, will be blind with the proliferative. I mean, because of the hemorrhaging and stuff, this is where they're going to end up totally losing their eyesight. So treatment, they can treat it with laser photocoagulation therapy. That is indicated to reduce the risk of vision loss in patients with proliferative retinopathy or macular edema, and in some cases non-proliferative retinopathy. They might try vitrectomy, which is an aspiration of blood, membranes, and fibers from inside the eye, because remember, you've got all that going into the vitreous with the hemorrhage and stuff with it, and drugs to block the action of vascular endothelial growth with it. So it just really is going to depend on the severity, where they are at it, and what's going on. It does require a special optometrist to help deal with it on that. So it just kind of depends on the severity and if it's proliferative or non-proliferative on types of treatment that they're going to do with it. So diabetic nephropathy, which is found on page 1149, is a microvascular complication associated with damage to the small blood vessels that supply the glomeruli of the kidney. It is the leading cause of end-stage kidney disease in the United States and is seen in 20 to 40% of people with diabetes. Risk factors for diabetes-related nephropathy include hypertension, genetic predisposition, smoking, and chronic hyperglycemia. So treatment is going to be managing blood glucose levels. It is considered effective in many but not all cases. Drug therapy may be used to treat neuropathic symptoms, particularly pain with it. So like I said, typically, the big thing is trying to control blood glucose levels with it. They will give some medications, I should say, to help deal with the pain. They might use like topical creams like capsaicin. They might try them on antidepressants. They might, try different things to kind of help with it. The capsaicin would be more for like pain mediating chemicals with the peripheral nervous sensory neurons. Once it's applied, tricyclic antidepressants are probably going to be the most commonly seen one. They are moderately effective in treating symptoms of diabetic neuropathy. Then you also might see them on anti-seizure medications such as gabapentin or Lyrica to help with, we're looking at the neuropathy pain with it. Diabetic neuropathy. This is a nerve damage that is caused by diabetes. Over time, high blood glucose levels, high levels of fats such as triglycerides in the blood formed from diabetes can cause damage to your nerves, and the symptoms are going to depend on the type of diabetic neuropathy you have. Is it going to be in your feet? Is it going to cause maybe problems with autonomic, which is where you're going to see like sexual function or erectile dysfunction, decreased libido? Is it going to be neurogenic bladder, where there's going to be a cause for urinary retention? It just kind of depends on where it is and what's going on with it. Erectile dysfunction or decreased libido with women with diabetes, you're going to have to, there's going to be some education. It's going to be a psychological factor. So you may be referring them maybe to a counselor to help with that. You definitely will need to be referring them to their healthcare provider to maybe help them with some medication or something along those lines. Neurogenic bladder may develop as the sensation of the inner bladder wall decreases, causing urinary retention. A patient with retention has infrequent voiding, difficulty in voiding, and a weak stream of urine. Emptying the bladder every 3 hours in a sitting position helps prevent stasis and subsequent infection. Tightening the abdominal wall during voiding and using the Crede's maneuver, which is mild massage downward over the lower abdomen and bladder, may help with complete bladder emptying. And cholinergic agonist drugs such as uracil may be used to help with that. And the person may also need to learn how to do self-catheterization. So you might be doing a lot with dealing with neurogenic bladders and with diabetic neuropathy. Pain can be uncomfortable and just kind of hard for them to deal sometimes with, especially in their feet. Okay, so foot complications found on page 1150. The development of diabetes-related foot complications can be the result of a combination of microvascular and macrovascular diseases that place the patient at risk for injury and serious infection. Sensory neuropathy and peripheral artery disease are risk factors of foot complications. In addition, clotting abnormalities, impaired immune function, and autonomic neuropathy also play a role. Smoking is deleterious to the health of the lower extremity. Basically, smoking is bad. That's all I'm saying on that one. Sensory neuropathy is a major risk factor for lower extremity amputations with people with diabetes. This is because there's a loss of protective sensations, preventing the patient from being aware that the foot is injured. A lot of diabetics you'll see with sores on their feet, and they will say, well, I didn't realize I had a rock in my shoe until I had my spouse look at my foot and see this big nasty sore on my foot, because they lost that sensation with it. So it's important that you teach them to look at their feet, look between their toes, make sure they have proper footwear, because the primary risk factor of lower extremity amputation is loss of protective sensation. Annual screening with monofilament is important. That's where they take a really fine needle and kind of poke in your toe, or I shouldn't say needle, but a really fine piece of metal, and poke your foot and see if you've got sensation with it. Also, seeing a foot doctor is also very important. Keeping toenails trimmed, making sure that they have socks, comfortable shoes with it. So it's very important. Also, look between their toes. Peripheral artery disease increases the risk of amputation by causing a reduction in blood flow to the lower extremities. When blood flow is decreased, oxygen, white blood cells, and vital nutrients are not able to get to the tissue. So and then you put diabetes on top of that, so the wound isn't going to heal. So you've got a lot of issues, and so eventually it's just a big storm waiting to happen a lot of times with the foot. So the biggest thing that I want you to take away from this one is check your feet. Check their feet very carefully and teach them to check their feet and what to watch for, and tell them that proper fitting shoes is essential so that they don't get sores. As persons with diabetes are more susceptible to infection, it's important that that you assess their knowledge and adherence to the plan of care. They understand that if they start, seeing that their blood sugars are creeping up there, that they need to get in to see the doctor. That if they start, feeling nauseous, signs of being sick, they need to get in to see their doctor so they can get a game plan to how they're going to treat it so they don't get sick, because they'll get sick faster and it'll take longer for them to bounce back with it. Important to have yearly eye exams. Sometimes they may go in twice a year with it. Dental exams. It's just very important that they understand they need to continue with this preventative care, so that they try to stay ahead of what is going on with it. So provide information, encourage health promotion activities, and recommend health screening. Very, very important. It's also important that during the education you're doing this, you bring the family members in, the significant other, the wife, the husband, the children, the grandchildren, the caregivers, everybody that is involved, that way everybody is on the same page. That way, they're not getting two different stories. The doctor says one thing and the patient says another to the spouse. Everybody is on the same page. Everybody knows what the expectations are with it. And if you notice at any time that you're doing any education and the patient is not understanding diet, bring that dietitian in. You need to bring the dietitian in to begin with, but if you start seeing get ready for them to go home and the patient is starting to talk about weird things to their diet, bring that dietitian back in. Make sure that they keep communications open with the dietitian and their healthcare provider so that there aren't any problems. There's going to be questions, so encourage them to call and talk to their healthcare provider. Hook them up with the American Diabetic Association also, and make sure that they also have a way to contact a dietitian to help them with their diet and meal like that. And that they have problems with medication or concerns, be sure you tell them to visit with their local pharmacist. That will help them, because that is that is one of the ways that we can keep people going. Keep them compliant and keep everything going the way it needs to go with them, and keep them healthy, is if you keep that line of communication open for them.